So with that, we will start our multidisciplinary team. Shahid, you stay sitting down, apparently. You can stay sitting down, and you take this. Yeah. So the multidisciplinary team, starting with the guy who quite often diagnoses your problem, the hepatologist. Shahid Khan works at Imperial, one of the foremost hepatologists on the planet. Go for it, Shahid.
Thank you. Checks in the post. My name's Shahid Khan. It's a real pleasure to be here. I am I'm a hepatologist. Hepatologists are liver specialists, and we are all trained gastroenterologists who have subspecialised in liver disease. And I've been asked to talk for a few minutes about my role, or people like me, our role in the multidisciplinary team panel. So, having a MDT, multidisciplinary team approach in cancer generally, in liver cancer particularly, is designed to ensure that patients get optimal care based on best practice, evidence-based guidelines. And there are many, many people who are involved because you need pathologists, you need oncologists, you need nurses, pharmacists for the drugs, radiologists, surgeons, and most of us are going to give our take on things and our role. So at the MDT, patient cases are discussed, and the idea is to come up with optimum treatment choices that can be taken back to the patient and their family. We are guided by national, international, and local guidelines. MDTs have to be core rate. You have to have a certain number of specialists, all who subspecialize in this field. The role of the MDT, in my mind, is not to make the final decision. At the end of the day, and I always advocate for the patient, at the end of the day, nothing, and I say to my patients that nothing's going to happen to you until you say that that's what you want to happen, right? So ultimately, the patient decides whether to accept the proposed management outcome from the MDT or not, or to get a second opinion, and sometimes the MDT comes up with 2 or 3 options for treatment. So in my particular role is really around the fact that patients with cholangiocarcinoma often have underlying liver disease. So for example, around 25–30% may have PSC, a chronic condition that causes liver cirrhosis, sometimes liver damage. And even if patients don't have PSC, there are other liver conditions that can predispose to cholangiocarcinoma. And for those patients, they have 2 issues. They've got the cancer, they've also got a liver that's not working optimally, which can limit some of the treatment options. So one of my roles is to make sure that patients who are at risk of cholangiocarcinoma are appropriately screened so that cancer, if it's happening, can be picked up as soon as possible. And patients with PSC are at risk of liver, cholangio, gallbladder cancer, as well as colorectal cancer if they have inflammatory bowel disease. So I do endoscopy, I do colonoscopy. Also to make sure that if they have underlying chronic liver disease as well, separate from the cancer, that is diagnosed appropriately and managed, and the liver function is optimized so that all the treatment options are hopefully potentially available. And also some of the treatments can have liver-related or gastrointestinal side effects. So, for example, bleeding, drug-induced liver injury, and again, managing and optimizing those things so that patients can... So really, it's like picking up the cancer early and then managing the liver function and any complications from treatment to optimize the patient's treatment pathways and choices. Many things can... there are many aspects of liver decompensation. So when the underlying liver isn't working, sometimes that might be from the cancer, sometimes that might be from the predisposing liver disease, sometimes that might be from the treatment. and it's managing and diagnosing that is one of our key roles. And one of the key things that many patients with cholangiocarcinoma undergo is ERCP, a procedure, an endoscopic procedure to put stents into blocked bile ducts or to get diagnosis from abnormal bile ducts, and that's a highly skilled procedure that some of my colleagues specialize in. One of the other key roles that I have, I think, is ensuring the correct assessment of liver function. And I'll give a couple of examples. So one of the key functions of how well the liver is working is someone's albumin level. So albumin is a protein that is made in the liver, and it has many important roles. It helps maintain fluid balance in your blood vessels, and it carries toxins for clearance. And a low albumin level is often a sign that the liver isn't working. The liver cells are failing, it's not making albumin, and that puts patients out, that excludes certain treatments. So I've had a couple of cases where patients were, the feeling was patient couldn't have radical treatment, for example, surgery, because their albumin was too low, and therefore their liver function was too poor, and they wouldn't survive surgery. In the first case there, this patient actually had, when I saw him in clinic, had diarrhea, and I did a colonoscopy and found that he actually had a separate condition. Well, he had a condition called microscopic colitis, which was why he was low in albumin, because his diarrhea was causing albumin loss. When I treated the colitis with a short course of steroids, his diarrhea stopped, his albumin went back to normal, and he was able to have surgery. And so that's again, interpreting the liver tests correctly. And another case, a 44-year-old lady who's had a high bilirubin level. So bilirubin's a yellow pigment. It's a waste product from old red blood cells, and the liver clears it. And if the liver is not working, bilirubin may not be cleared, and so that may be a sign, a high bilirubin, that the liver's not working. And again, that would exclude certain treatments. But there are other causes of a high bilirubin, and I found out that this patient had something called Gilbert syndrome, which is completely benign. It's just where the bilirubin levels are slowly metabolized. It has no it's not indicative of liver function. And then I could prove to the MDT that this person, high bilirubin, was not due to liver failure, and then that opened up more treatment options. So that's just a snapshot of my role as a hepatologist and a gastroenterologist in the MDT.
Thank you, Shahid, for this presentation. Good afternoon and welcome also from my side to you all. Next speaker is not here. Professor Robert Goldin is a well-known pathologist. He will be given his lecture. The lecture has been pre-recorded, but he will be able to address your question live via Zoom. So Professor Rob Goldin from Imperial College here in UK. And so I think the presentation may start.
Good afternoon. I'm very sorry not to be able to be with you in person, but I'm very grateful to have the opportunity of sending you this recording. I'm Rob Golden. I'm a histopathologist at Imperial College. I'm a colleague of Shahid Khan's, which is a good claim to fame. And I'm going to tell you a little bit about the pathologist's contribution to the MDT. But I think before I do that, I need to tell you a little bit what histopathologists do. Now, this is what the Royal College of Pathologists tells me. We are the science behind the cure. Histopathologists are medically qualified doctors, but we're probably the kind of doctor you're least likely to meet in your journey as a patient or as a member of family of a patient. So we are both literally and metaphorically behind the cure. We're very interested in what causes diseases, how these diseases cause changes to tissues, how these can be used in terms of diagnosis or planning new therapies. And so whenever a biopsy is taken or a cytology sample, they are sent to histopathologists, and then you get the result back from us. Now, if you're interested in learning more, I hope you may not be entirely put off by my presentation about what histopathologists do. I just included a link here to a video. Again, I have to say produced by the Royal College, but it's a very nice presentation by my colleague, Dr. Mark Howard. I'm not at King's College, by the way. who can give you a bit more detail. You see he's got a good old-fashioned microscope behind him. We actually use slightly more modern microscopes than that. That looks like the kind of microscope you might use for an A-level biology class. So the college is very committed to improving levels of patient care. This is just an example. I was part of a group of pathologists who defined the ways in which liver resection specimens, including cholangiocarcinomas and gallbladder cancers, should be reported so that when people report them all over the country, a uniform approach can be made. And that's really, I think, an important thing. So let's just look now at the kinds of things histopathologists do. First of all, we report biopsies. A specimen is taken by a needle, at endoscopy, or by some technique. We convert them into glass slides, and then we look at them under the microscope. Here, for example, is an example of a small duct cholangiocarcinoma. But now let's consider the role of the pathologist in a little bit more detail. When we have a biopsy, what are the questions that we're asked to answer? First of all, of course, most importantly, is it cancer? Is it perhaps some inflammatory process? Is it IgG4 related disease? There are a number of conditions which can mimic cancer, and that is the first thing we have to do is to say, this is cancer or this is not cancer. If it is a cancer, then of course we need to decide what kind of cancer it is. If it's a needle biopsy of the liver, we might be wondering whether it's a tumor of liver cells, a tumor from the bile ducts, or maybe a tumor coming from another part of the body. These are all questions that we have to address. Really importantly, and we are increasingly asked to provide information that will plan patient treatment. So not only will you look at it and do some stains ourselves, but now we are being asked to provide tissue for molecular studies, which will allow the oncologist to plan more personalized treatment. And the pathologist is really important in selecting appropriate samples for this kind of task. Something which I think really needs to be highlighted in terms of what the pathologist does at the MDT is review cases. So, for example, at Imperial, we receive patients referred to us from quite a wide catchment area about the expert opinions of our oncologists and surgeons, but coming with them is pathology, and we are asked to review those. Now, I am very specialized in what I do, and many of the pathologist reports specimens are less specialized. That doesn't make them less good pathologists. It just means they're less expert in the very little area of which I know a little bit more. So reviewing slides is really important because we don't always agree with how they've been assessed. And so this is a very critical part of the MDT review. Then, of course, if the patient has a resection and the tumor is cut out, then we are given those specimens to assess. Here is an example of one here. Here is a cholangiocarcinoma arising in the left hepatic duct. You can see the right hepatic duct down here, and then there's the common bile duct. So we can identify exactly where it is, sample it properly, and check whether it's all out. So again, we need to confirm it's cancer because there are a small number of patients who we are not able to review the biopsies before surgery, and that's important. Very important for us is to record the specimen in a way that other people can share in that information. And of course, with the advent of digital photography, that's made much easier. The slide I just showed you is an example of it. Perhaps the most important question we're asked to address is how far is the tumor spread? That's the stage of the tumor. And is it completely excised? That, of course, is the question the surgeons, the oncologists, and most of all the patients are interested in to know, is it all out? And again, as I said, for biopsies, and a very important part of what we do is set aside material. We specifically take additional material so that if later down the line somebody wants additional tests done, we can do that. Now, histopathologists, in terms of attending the MDT, we are all members of the MDT. Here, all the MDTs, of course, used to be in person. Now, of course, this is one illustrates here. We do most of them by Zoom. But nevertheless, we are part of a team of people all working together to get the best result for the patient. We are very involved in researching clinical trials, in identifying patients who are suitable for particular clinical trials. Sometimes we are actually the pathologists who are leading on the pathology for clinical trials. And that's a very, very important part of pathology, particularly important to me as a way in which pathologists can contribute to improving patient care. Histopathology is moving. Currently, most of us are using microscopes like the nice one there on the left, but everything is going digital. We talk about digital photography for whole specimens. Now we're looking at digital imaging of slides. This is with us now. We aren't using it maximally yet, but we will do. And this will allow pathologists to share slides from across the country, allow us to share our expertise, to share our problems, and I think is going to be very important. We all hear a lot about AI, and AI will certainly be applied to the analysis of these digital images, we hope, again, to the benefit of patients. Really sorry not to be with you. One of the joys of the AMMF meetings is a chance for pathologists like me who don't often get a chance to talk to patients and their families to do so, and I hope I will have opportunity to do so in the future. Thank you very much.
Okay, so thank you, Rob. That's pre-recorded, but he will be here for the answer and question session. So if you want to ask him anything, please put it on the app, and we'll come to it in the Q&A. Next up, Hassan Malik, who is a hepatobiliary surgeon from Aintree, currently the chair of the National Cancer Research Institute Upper GI Group. Thank you, Hassan.
Thanks, John, and everyone can hear me okay. And I do recognise a few friendly faces in the audience. So the role of surgeon, I think I'm going to probably cover some of the stuff that Shahid's already mentioned, and basically, what factor is it that we look at when we're planning for an operation? The first thing is, can you remove it? Now, if you put 10 surgeons in a room, you'll probably get 12 different answers. And that's the difficulty about consistency of decision making. As people who treat cancer, we see ourselves as surgical oncologists, so it's also about, okay, you might be able to remove something, but is it sensible to do so? Is it going to provide actual added value? Because whatever we do has significant morbidity and mortality. So it's about balancing those risks. But also, I think it's important to know the patient's comorbidities, their ability to tolerate what we're proposing. And often I go and talk at various kind of conferences and training things about surgery, and you see people talking about things, and then people will think, okay, I can just jump on this and do it myself. But you need to understand your team and your centre, and can they deliver that type of care? That you might see a video of something, but can you actually achieve that type of result in your own hands? And the key thing with surgery is, this is data from Liverpool, surgery basically still remains the only curative intent option. Now, whether that be resectional surgery, where you remove the cancer with part of the liver, the bile duct, whatever, or with the new things like transplantation is still an operation, it's the only chance of cure. And this is data, I think, of about 500-600 patients with cholangiocarcinoma we've treated in Liverpool, comparing the red line, which is chemotherapy, with surgery in terms of the median survival. The challenge also remains there's a lot of patients who come through our tumour board who unfortunately aren't fit enough for anything. Oh, so this keeps racing. The other difficulty is about that decision making. Now, this is probably the most important slide I've got to show. This is data from the International Perihilar Cholangiocarcinoma Collaborative. It's a surgical collaborative. It's led out of the EMC, Amsterdam Medical Centre. And there's about 1,700 patients who've had a resection. But in 16% of cases, that was futile. They either died of their surgery or they succumbed from recurrent disease early on. So the decision-making side of things is crucial. And it comes back to the MDT. The MDT is there to protect you as a patient from perhaps decisions that can be not supported by evidence. Because anything we do, whether it be surgery, chemotherapy, whatever, has risks. Now, in terms of the MDT itself, and then taking it back a step, the MDT was controversial when first proposed. A lot of people would sit and say, well, I know best. Unfortunately, one person doesn't have all the answers. But there is good evidence that this is the best way of treating cancer. Now, maybe in the future, AI has a role in that. At the moment, it's done by humans. And it is a legal requirement in many countries, and certainly in the UK it is. And And the MDT is a decision-making machine. That's basically what it's about, okay? And what decision-making is, it's about reaching a judgment once you've assessed the situation, and it has a number of steps. So you assess the situation, you generate some options, you would select an option, and obviously the patient is part of that selection process. And I think the outcome review is important, and not all MDTs will review their outcomes. And one of the best ways of reviewing your outcomes as an MDT or a service is to publish papers. And certainly in Liverpool, if you want to know our data, it's been published in a number of journals. Just go into PubMed and you'll find our names. So if you look at a patient with a cholangiocarcinoma, these are, again, oops, this is just racing away. So this is the complexity of that decision-making process in terms of the options, in terms of assessing the situation, the progression of disease, generating options, etc. Now, in Liverpool, we'll probably be discussing 40 patients in a 2-hour slot with primary liver cancer. So that's, on average, 3 minutes to make a life and death decision. Just think about that. And if you're the patient at the end of that process. So coming back to all that, we can risk stratify, and certainly for cholangiocarcinoma surgery, it's in the kind of top right-hand corner, that's in red. So surgery for cholangiocarcinoma is all about planning. Patients who have this surgery will invariably have complications, and we need to be able to predict and avoid and deal with them. And the key thing is that it's all about team working and having a really an excellent team to deliver optimal outcomes. Thank you.
Thank you. Next speaker is Professor Juan Valle. We move to the medical oncologist. Professor Juan Valle, is, you all know him, is dedicated, fully dedicated to cholangiocarcinoma, and he works at the University of Manchester and the Christie.
Thank you, Lorenzo, and for the organizers for the invitation. So I've put meet the oncologist, but those of you who are keen-eyed will have noticed there's 2 oncologists here. So I'm a medical oncologist, which means I deal with systemic treatments. I don't deal with radiation oncologists like Ganesh, who's going to speak next, and who forgot to turn his phone off. There's always one at the MDT. So what I wanted to do is actually take you through a real-life MDT example. This was our MDT about 3 weeks ago. It was a relatively light MDT. We discussed 26 patients. Of those, 10 patients didn't have a cancer. Now, that doesn't mean that they didn't need to be discussed. In fact, often patients without cancer can be very complex cases, and sometimes the discussion takes longer than some of the oncology patients. But as an oncologist, I don't really feel that I can offer very much in that situation. So at least I get a little bit of breathing time in between the other cases. The other 16 patients were made up of 8 patients who had a cholangiocarcinoma, 4 patients with gallbladder cancer, and 4 patients with primary liver cancer, hepatocellular carcinoma. And if I just take you through the cholangiocarcinoma patients, the decision was for 2 of them to proceed to surgery. 5 patients were to come through to chemotherapy. I've said chemotherapy, systemic therapy. Of course, we have some other treatments available. And 1 patient, the decision was for best supportive care, which means no active anti-cancer treatment, but offering comfort care or support of symptoms that may be causing distress. Among the patients with gallbladder cancer, 2 were to be referred across to us in medical oncology. 2 patients were not fit enough for any treatment, and the recommendation was again for best supportive care. And with primary liver cancer, 1 patient for surgery, 1 for chemotherapy, and 2 for best supportive care. Our role as an oncologist is to be absolutely sure about the diagnosis. And one of the things that we're known for is pushing for tissue. Have we got a confirmed diagnosis, cytology, histology, that this is a cancer? And you heard Rob Golding talking about those. Of course, evaluating the scans as well at the MDT. But predominantly, our role is in managing the patients who are then referred for systemic treatments. And usually we're able to make a much more detailed assessment than that information that's provided to the MDT, which is sometimes fairly scanty. So we assess the patient's fitness, We take some time to go into the family history as well as any other medical problems and other medication the patient may be taking. It's usually at this point that we're also beginning to discuss molecular profiling, because we know we want to think about this at some point in the treatment pathway. And then we're able to discuss with patients standard treatment options. We're very keen to enroll patients in clinical trials, and our new patient clinic is in parallel to our clinical trial clinic, so that we're able to offer trials to all patients if they're eligible. And as with other centers, we also invite patients to participate in biobanking so that small amounts of tissue can be retained for future research to help us understand the disease a lot better. But that's not all we do. In patients who undergo surgery, we then get involved after the operation, answering the question, does the patient need chemotherapy after surgery? And this is what we call the adjuvant setting, and this is aimed at keeping patients cured and reducing the chance of disease recurrence. Sometimes patients might need chemotherapy before surgery. Again, we're trying to render somebody who's got inoperable disease operable, and then they can go and have a potentially curative operation. And the other thing that we sometimes forget is that if patients are receiving systemic treatment for what we think is advanced disease, have they responded particularly well to chemotherapy, and is surgery now possible that maybe wasn't possible when they were first assessed? How can patients get involved? Well, we know that this benefits patients because they have a very detailed assessment at their outpatient appointment. We're usually the ones that then refer selected patients to clinical genetics if we feel that they need to have a family history explored in more detail. Participation in research is core to what we do, and they also, of course, have access to the whole oncology team. In terms of patient advocacy and involvement, this is usually done by the clinical nurse specialist, and you'll hear more about this in a few moments. But if we take the patients back to the MDT after oncological treatment, then we usually advocate for the patients if we're thinking, for example, about surgery or indeed radiotherapy. Patient views are always taken into consideration, and in fact, patients make the final decision, and the feedback from the MDT is usually face-to-face at the outpatient clinic consultation. Thank you.
Great. Thanks very much, Juan. And now to Dr. Ganesh Radhakrishna, who is a radiation oncologist, Juan's colleague at the Christie. Ganesh,
Thank you.
please.
Thank you, and apologies again for not switching off my phone. There's always one reprobate in the MDT. It's one of my roles. I'm a clinical oncologist, and this is a very much a UK concept. So very briefly, a clinical oncologist is someone who covers all aspects of non-surgical management in both the curative and metastatic malignant disease. And the reason why I'm saying that is there are certain centers where your oncologist may be a clinical oncologist who might deliver the systemic therapy as well on occasion. However, in cholangiocarcinoma, particularly in primary liver cancers, we now are increasingly becoming more complex with our treatments, and increasingly people like myself, who are clinical oncologists, are becoming more aligned to what the Europeans and the North Americans call radiation oncologists, where we deliver very highly complex precision radiation therapy. We tend to be generally quite peripheral in the MDT. However, our role is slowly increasing with the newer treatments that we're able to offer. This could include simple things. So as Juan highlighted earlier, patients who may be considered for best supportive care sometimes have pain from their secondaries. If their cancers unfortunately spread to the bone, radiotherapy can be a very effective treatment in that setting. And it may also be used for consolidation after systemic therapy to maximize local control when surgery is not an option. And we're also heavily involved in clinical trials, like the recent trial called ABC07, and a trial which I will briefly touch on at the end. Very busy slide, but essentially a radiation oncologist uses X-rays, predominantly photons, to treat cancers. X-rays are used routinely. CT scans are X-rays. The X-rays that we use, however, are about tens of thousands of times more intense than normal X-ray. and therefore it has an anti-cancer effect. And we use that to essentially focus on the area where the cancer is to try and maximize control and increase cancer cell death. We use multimodality imaging. If there is an imaging modality out there, MR, CT, PET, anything, we use them all. And we integrate that to improve the precision of the radiation and also try and minimize any damage to cells that may be around the tumor, so we call normal tissue damage. So as a standard, in the UK, most centres are delivering radiotherapy with what we call radical or definitive intent. So patients who've got localized disease, we would use something called image-guided intensity modulated radiotherapy, which obviously rolls off your tongue. But it's a high precision form of radiation where we image the patient whilst they're even having their treatment. And the step up from that is SABR, stereotactic ablative body radiotherapy, or SBRT. So what we would do in this situation, and this is a very loose analogy, if you imagine a conventional treatment involves 3, 4, 5 weeks of treatment daily, Monday to Friday. With SABR, we effectively deliver the same biological dose in 3 to 5 treatments. So very intense doses of radiation, very precisely delivered to the tumor. And sometimes that's used with drug therapy. But in the main, SABR is given usually after drug therapy. It's never given concurrently. I put another point, which is in the fine print there, about brachytherapy. Brachytherapy is using internal radiation, usually for cholangiocarcinomas of the hilar, where you deliver the dose through an iridium implant, and it's irradiating from the inside out. So another form of high precision radiation, but very complex and not commonly used. And obviously palliative, as I mentioned earlier. All major centers have got a linear accelerator, and on the left, on the top 2 slides on your left, are the commonly used linear accelerators. They're big X-ray machines. You're not in a tunnel, everything is open, and your patients are often in a big bunker, which is to avoid any leakage of radiation to others. The radiation that we use is so intense that a lead apron has absolutely no effect whatsoever. So patients are monitored via CCTV. At the bottom left, we've got 2 older machines. So the one that is on the top there with looks like it's got an arm that's moving around, that's commonly referred to as CyberKnife. So that's a non-gantry-based radiation machine where the X-rays are delivered from that arm. But the more commonly used ones are the ones on the top. What we are looking at with those images are images that we get whilst the patient's on treatment. The grainy image that you see on the left is called a cone beam CT. And what we're able to do with that, and this is obviously selected to look particularly bad, it gives us an idea of where the tumor is, so we can focus the X-rays and we know we're hitting the target when the patient's having it. The most recent technology that you have on the right-hand side is MR-guided radiotherapy, which allows us to obviously see the tumor much more clearly on treatment, but it also gives us an opportunity to start looking at functional imaging. So patients, like Professor Shahid had mentioned earlier, who have primary sclerosing cholangitis may have poor liver function. We may not necessarily know where that area is, but with MR we can potentially identify that and spare the normal liver. And this is proton beam therapy. So on the right-hand side of the scan, the area that is being irradiated, and that's, as it scrolls back up again, is in red, is where the tumor is. And we're using conventional radiation. You can see it comes in from multiple directions, and it's focused on that one area over there, but there's a lot of liver that gets some background radiation. On the right, you have proton beam therapy, which, due to its natural particle physics, it's able to stop, so we don't have what we call an exit dose, so there's less radiation to the normal liver. And why is that important? Well, it's important because it enables us to spare a substantial amount of normal tissue. And what we're able to therefore do is, which unfortunately hasn't been very well color-coded in the graph, is we can spare a lot more of the normal liver, and we can intensify the dose of radiation to the primary tumor with proton beam therapy. And that's what that graph is essentially showing. And we have now got funding and a collaboration between NHS England and NHS Blood and Transplant as a commission treatment for using proton beam therapy in selected patients with hilar cholangiocarcinoma pre-transplant. That's all I have to say. We work as a part of a massive MDT, and I'm very grateful to all my colleagues for supporting me. Thank you.
Great, thank you. Now we have the next presentation that will be given by Louise Jones and Margaret Griffin, hepatopancreatobiliary clinical nurse specialists. Nurses are key in all the steps of the multidisciplinary decisions, and in the management of the patients, of course.
Okay, so Louise and I are going to talk about the role of the clinical nurse specialist within the MDT. So the clinical nurse specialist has many and varied responsibilities, but for the purpose of the presentation, we'll focus on what we consider to be the most important aspects of our role. So we believe that communication is fundamental to our role. Communication with patients, with their families, the parent team, and the wider MDT. We act as a key worker for the patient from the first point of contact right through the patient pathway. Patients and their families have complex information to absorb and process, often within a short space of time. And we know from experience that the message transmitted in clinic is not always the message received, and sometimes only part of the message is received. As clinical nurse specialists, a large part of our role is about making sure that the patient understands their diagnosis and treatment plan, and the rationale behind it, reviewing and discussing this information as often as needed and at the right pace for the patient, helping them to understand why they can or can't have particular treatments and why their plan may change if additional sites of disease are revealed with further investigation. So we also feel that another significant part of our role is to act as an information resource. We try to provide patients and their families with information in a format that works for them. We start with a written summary of their treatment plan and ensure they have our contact details so that we can discuss concerns over the telephone or via email. And we also provide them with written information from reliable sources, for example, the AMMF, from Macmillan, and have links to their websites as well. So we also endeavour to provide ongoing support for our patients and their families. We aim to tailor support to what the patient and the families need, and we use the Macmillan Holistic Needs Assessment to identify the most significant concerns for the patient, and from this, signpost the patient to services that may help them. For example, support from peers via the AMMF or the local Maggie's Centre, counselling from the Macmillan support line, benefits advice, or ongoing referral for clinical psychology services.
I'm now going to look at three more components of the role of the clinical nurse specialist within the multidisciplinary team. So the first one is around guidance, and I see that this is split into two parts. The first part is guidance during the multidisciplinary team meeting. Now, it's already been mentioned on the panel that this is a weekly meeting where the patient is discussed, and that can be many, many discussions that do take place. During this meeting, the clinical nurse specialist will act as the patient advocate. So it's really important that the information provided to us from the local team, because often at this point we've not even met the patient, is relayed to the wider MDT so that the right decision is made or formulated and the treatment plan's formulated. We work really closely with our referring trusts, and we can also provide guidance within the management of this disease as well. So it's important that we develop good networking and that we develop good working relationships. We can then ensure that patients are referred to us in a timely fashion and that also with the correct information so that the MDT discussion is a meaningful one. We also then can provide guidance for the ongoing management of this complex disease, and we can be there as a team to signpost and to provide advice. So if a patient becomes jaundiced, what's the next step? Because it's crucial that patients are treated timely. And then after the multidisciplinary team meeting, it's our responsibility to then liaise back with the referring teams about that MDT outcome and that discussion and what the fundamentals of that discussion and what we decided. Then that discussion will then be relayed back to the patient and we can then liaise with the referring team and the patient if required. Often patients will then be referred into the tertiary centre and we can let them know the timescale of the clinic appointment. Another key part of our role is the pathway management. So that's the patient pathway management. And it's an integral part that we case manage this patient pathway. It's important that we drive forward the pathway to ensure that referrals, investigations and reviews are done in a timely fashion. Now, as other speakers have said today, that patient pathway is a complex one with many different investigations required, different reviews by different team members, and the clinical nurse specialist pulls all that together. The role has often been likened to a conductor of an orchestra, with the multidisciplinary team members forming sections of the orchestra and the nurse specialist pulling all those sections together and ensuring that the patient pathway runs as seamless, and again, I'll use the word timely as possible. So we work really closely with the MDT. You can often find us knocking on office doors. We get to know all the secretaries, we get to know the team really well, we'll constantly liaising, we're emailing, and all to make sure that that pathway moves. And finally, service development. The clinical nurse specialist plays an integral part in developing the cholangiocarcinoma service. It's important that the nurse specialist is aware of national standards to make sure that they're implemented locally and that they work together with the local trust to drive those standards. And also from a clinical nurse specialist point of view to make sure that any national Macmillan or Department of Health initiatives are implemented into our cancer pathway to ensure that we're providing the most effective patient evidence-based care. So as you can see in summary, the clinical nurse specialist plays a vital role in the management within the MDT. Thank you.
That's great. Thanks very much, team.